We have begun our recording, so let me first launch with Rachel Wick. Good morning, Rachel.
Good morning, everyone, or almost good afternoon. This is Rachel Wick, Senior Program Officer at Blue Shield of California Foundation. Thank you all for being on the call today and for your partnership with us in our eConsult initiative. Next slide, please. So this is our foundation's spread strategy. What is our thinking behind how you really plan and implement eConsult across several communities in California? Our theory is that you really have to simultaneously hold and work on these four things: the stakeholder engagement, physician and executive buy-in, the relationships piece is so important and I think often overlooked. So I just want to continually put a plug in for your relational work that you're doing on eConsult in bringing together primary care and specialists as well as executive champions and frontline staff. It's a very complex undertaking and those relationships need a lot of attention. We're also working actively on how do we really leverage technology to support eConsult and drive our implementation efforts. And again, another very complex undertaking, as many of you know from your work in your local communities and with partners and with Blue Path Health. The two components that we're really zeroing in on the webinar today are the ones on the bottom of this slide, which are shared measurement and policy. And really for us, I think today we'll get at the real nexus between the two strategies, and look forward to having both Delphine and David lead us in a conversation about how do we really develop a set of core measures that are aligned with and driving and informing policy in California. And today we're going to hear about the policy opportunities under the waiver. We also think of policy being your engagement with health plans and payers on what is the business case that they're looking for in terms of paying for eConsult. And so we're sort of holding, again, measurement and policy together in the conversation today. Next slide, please. So this is really the foundation's approach to evaluation in this initiative. This is what we set out, sort of what our framework was when we set out. The first thing, the goal is really to spread an innovation that works. So in terms of this evaluation, the goal of it is not to say, do we think eConsult is an effective intervention? About a year and a half ago, when we convened expert stakeholders and implementers from around the country, one of the things they said to us was no more pilots, but the innovation doesn't need to sort of prove concept. And so what we are doing in our evaluation approach is really focusing on how can we demonstrate the value of eConsult, and that's really through the quadruple aim framework. And again, you'll see this reflected in the measurement. Our goal is to inform and be informed by the policy environment. The approach we designed was really focused on supporting you, the grantees, in developing the framework, in addressing data collection issues in your local communities, and then ultimately collecting and having you submit the data to the UCSF SFGH team. And the purpose of this really is to, one, kind of aggregate the data to get at the field impact. So what is the impact when the foundation supports a broad-scale implementation of something? How can we begin to roll up the impact of the initiative as a whole, and really communicate that to the foundation, back to our foundation, and to the broader field? And so that was really, these are kind of the components, the design pieces that we went into the initiative with. Next slide, please. So one of the things I want to highlight, this is just to give you a sense of where we're perceiving the communities to be across the state in terms of their phase of implementation. One of the things we've realized with 1 year of work kind of underway is there's a lot that happens in that feasibility phase, and it's really taking communities quite a long time, longer than we thought, and maybe you all thought too, to really move through some of the key issues around feasibility. And so I just want to we're going to have a very forward-looking conversation today about measurement, but I just want to call this out to acknowledge that I know many of you are not at the stage of implementation yet, and so I'm asking you to really kind of hold. I understand where you're at, but also I want you to see the future as you think toward implementation and what measurement would look like once you start to implement. We do have some sites that are in active piloting and planning and piloting, and so I think the measurement strategy that we're going to talk about today will be quite real for them in terms of thinking about how are they going to sort of look at the impact of their implementation efforts. So today, again, what we're striving for with the evaluation is we want consensus on a set of core measures, and for the reasons that I talked about in terms of the strategy, we want your help in arriving at that set, thinking about feasibility, thinking about are these the right measures for impact, and then ultimately we want to collect and aggregate those measures that we agreed upon. And then the other thing I want to just call out is concurrently the foundation here, myself and Joycelyn Macbeth, we want to engage with you in some interviews to really get a sense kind of more qualitatively of your lessons learned from the first year of work. And I know some of you are relatively new to the cohort, so we're really looking at folks who have about a year of work underway. And we'll also be working with our partners at UCSF, SFGH to do a survey. So again, we want to concurrently, as we look at the data collection strategy and the metrics piece, we also want to hold the rich, qualitative lessons learned that you all have from the work that you've been doing over the last year. So I think that's it for me. I'll stop there and turn it over to Delphine. But again, thank you for your leadership and your contributions and your work on advancing eConsult.
Thank you, Rachel. Delphine.
Excellent. Thank you so much for that introduction, Rachel. So our goal for today was to focus on the evaluation framework, looking at the impact of eConsult. As Rachel just mentioned, we are also equally cognizant of all the work and the evaluation that needs to happen for the planning phases of eConsult. And we will be working with Rachel and her colleagues to develop an instrument to really focus on reflective thinking and how far we've come and lessons learned over the past years, or the past year, I should say, so that we can share with each other and other groups moving forward to how to plan and how to set up this really important work. So with that in mind, that would be the first part of the evaluation. The piece that we wanted to focus on today was the more forward-thinking piece, which is on the impact of eConsult. Next slide. So many of you have seen this already. Our group, based on literature review, based on lots of interviews with groups that have already piloted eConsult and are slightly more forward or advanced than we are at the moment, we have a draft set of core metrics that we have created in an evaluation framework. This is still in draft form, which is why we would love and really hope to get your feedback on this in terms of both feasibility as well as certain definitions. Just to orient you a little bit to the framework, you have here on the left-hand side, we tried to identify them within the quadruple aim. So we have for the first two aims here, the financial part of the quadruple aim, the population health part of the quadruple aim, and we'll get into the other aims on a subsequent slide. We have then identified which of these core metrics are directly related to some of the Medicaid waiver programs that you will shortly hear about, because our goal was to align measures and metrics so that we don't create unnecessary work and really try to identify definitions that make sense for multiple programs at the same time. And so you see here that certain columns are checked for those measures that we feel are directly related to crime, as well as those directly related to GPP, or the Global Payment Program. And lastly, we have some measures that are not directly related to either one of those programs, but based on our previous conversations with payers and with other health plans, these are items that they felt would inform future reimbursement and would be important to engage them at the table. Next slide. These are the other two components, or the other two arms of that quadruple aim framework. You see the rest of the population health arm, the care team experience arm, which focuses on satisfaction by all members of the care team, primary care providers, specialists, and staff members. And then lastly, we have a set of what we call supplementary metrics, because we feel like this is harder to capture, but these are really metrics that are aimed at capturing the patient experience, which has been a clear voice, which is clearly important whenever we innovate within the healthcare delivery system, but has also been voiced to us by Medi-Cal in particular and other payment and other health plans, that this is really important for them moving forward and is clearly important for us to think about. And so I wanted to just show you this framework and really highlight how these may be related to PRIME and GPP, the Global Payment Program. And I think what we will do next is allow David and his colleagues and Libby and her colleagues to really highlight those two programs so that you can start to understand where where they may align with eConsult programs, and then come back to me, and then we can talk about one or two of these metrics in particular so that we can start taking a deep dive and starting to talk about, one, are they each of these feasible? And two, are they meaningful for you? And three, what kind of definition might we achieve consensus on? When I come back on, our goal is to talk about a few of these to jumpstart the conversation. And then your homework at the end of this will be to take this back to your group. And if you haven't had a chance already, highlight and look at each one of these and really see whether they are feasible, whether they are meaningful, and if so, what kind of definition, i.e. what's the numerator and what's the denominator that would make most sense for your health system. We will then reach out to each one of you to make sure that we know your opinions and get your feedback on each of these, try to achieve consensus among the group, and send that consensus group of metrics out for further conversation. So with that, I will stop with this introduction and allow David, I think, and Libby to comment.
Thanks, Delphine. I think that you did the transition well here. I don't have much to add in that other than to introduce Dr. David Lone, who's been a great partner as we discuss waiver programs and how they align with Blue Shield program measures. So Dr. David Lone is going to review the different components of the waiver. And after that, we'll go back to your matrix, Delphine, and look at the crosswalk of these measures. So, David, I'm going to hand it over to you, and thanks for talking about the specifics of the programs. After David does review the next few slides, it would be a great opportunity to ask him some questions about these programs, as he was a key contributor to their creation. David?
Sure. Thanks, Libby. Thank you. So since we've got a couple minutes, I think I'll start by reviewing page by page the roughly 500 to 600 pages of the standard terms and conditions of the waiver. I think that should suffice for the next couple minutes. Just kidding. So why don't we switch to the next slide. What I'll be doing is going over the three major programs under the new 1115 Medi-Cal waiver that either have direct relation to eConsult or a potential relation to eConsult. So the three programs that I'll be talking about are PRIME, which is, as you can see, the public hospital redesign in Medi-Cal. The ME is, I guess, the ME of the Medi-Cal. The Global Payment Program for the remaining uninsured, and whole person care pilots. So PRIME, for those of you in the public health system sector, know that this is built on what was called the DSRIP, which was the Delivery System Reform Incentive Program, massive pay-for-performance program under the last waiver, the 2010 to 2015 waiver. That program involved the designated public hospitals. This is a legal term at the state level that includes the 12 county-run health systems and the 5 UC med centers. That program incorporated both infrastructure redesign and performance improvement clinical outcome efforts. Prime has built on that and focuses mainly and pays solely on achievement of targets of mostly clinical, some process outcome measures, but all of them either have or will have very specific benchmarks, and the participants will need to make improvements on a year-over-year effort in order to get paid. And I'll talk about the participants in a little bit more later. There's also a requirement around for the designated public hospitals around contracting with their managed care plans using alternative payment methodologies. This is essentially a movement towards value-based care. And I'm not going to talk a lot about that right now because it doesn't come into play until future years. The next program is the Global Payment Program for the Remaining Uninsured, and as the title suggests, focuses on those who remain uninsured and the provision of services to those individuals. And the focus is on providing services, and that's how reimbursement occurs. Big part of this program, which is the first of its kind in the country, is moving away from a strict cost-based program, cost-based payment, to a point-based program based on the various services all the way from inpatient to ambulatory services, and that each designated public hospital has a global budget related to those points. The big thing also is that it focuses on ambulatory care and really tries to promote the use of preventive and upstream services, including eConsults, to provide better care to the uninsured. The last one that I'll talk about is whole person care pilots, which is focused on the integration and the coordination of physical and behavioral health services as well as community or social services for individuals who are high utilizers of multiple systems, meaning the physical health system, the behavioral health system, possibly the justice system, native housing, etc. And this is a collaborative effort between the multiple systems, including the plans, that is needed to share data and coordinate care in real time. Next slide, please. So the first one I'll talk about is Prime. And you can see here the overall goal of Prime, just similarly as DSRIP had, was to improve the quality and value of care provided by safety net health systems. And Prime, as compared to DSRIP, has a much bigger focus on the ambulatory setting. There are 18 different possible projects, 6 of which are required for the public health systems, for the counties and the UCs, and the majority of them are ambulatory focused. You can see here the population is actually independent of coverage for a large part, but also does bring in assigned lives under managed care for primary care, whereas the previous DSRIP program really was just focused on those who have been seen by the health system. Another difference this time around is that in addition to the designated public hospitals, the 42 district and municipal hospitals are able to participate, and we understand that about 39 of them are going to be participating, engaging in anywhere from 1 to 10 or more projects. Won't say a lot about the funding. There's certainly federal and non-federal share, and this program, while officially approved December 31st, the measurement year started back in July of this past year and goes through June 2020. So I mentioned that there are 18 projects. One of the projects is specifically about ambulatory care redesign for specialty care, and that's focused both on the improvement of specialty care provided within the specialty clinic, but also the collaboration between specialty and primary care, enhancing the capacity of primary care to care for more complex patients. And within that, some of the metrics, as you see here, relate specifically to that relationship between the sort of the demand on specialty care from primary and others, and the ability of specialty care to match that demand. So we have metrics around how quickly are requests for specialty expertise being responded to, how many of those requests are being managed through non-face-to-face encounters, and then closing the loop afterwards, how many of those engagements that do result in a visit have a report sent back to the referring providers. And you can see here we have several of the county and UCs that have been functioning as measure stewards. Not surprisingly, San Francisco and LA certainly using some of these metrics already that show up in the eConsult Blue Shield program evaluation. Next slide. I'll go through all three of these just for time-wise, and then we can sort of take questions at the end. So Global Payment Program, as I mentioned, this is for the remaining uninsured, specifically for the remaining uninsured. And it's not just that the person is uninsured in general, but it's they're uninsured for the service that they're receiving. So certainly individuals who have emergency Medi-Cal and can get services on the inpatient side, but might not be covered after a certain period of time, or have limited scope Medi-Cal, or similar something where they're covered for inpatient but not outpatient. Those services can be covered under this program. Again, this is a July of 2015 through June of 2020 program. The funding of this is a little bit up in the air because it's a combination of the typical disproportionate share hospital dollars and uncompensated care pool dollars, which may be determined at a later point. But really, this is a big thing about this is that it expands the care under this program to include the whole breadth of care, from inpatient, the highest, ICU, all the way to face-to-face, but now also including what we're calling non-traditional services, as you can see under the service categories, things such as panel management, group visits, paramedicine treat and release, and a whole section on technology-based care that really is where the eConsults come in. So you can see provider-provider eConsults do receive points under this program, and we anticipate many entities participating in this program will be using this as a means to gain their points and provide better care. I put up here the point value establishment criteria. I won't go into this in detail, but every service on the Global Payment Program has points related to it. And particularly for the non-traditional services, we looked at some of these criteria, particularly the ability to increase access to care, to provide earlier intervention, and appropriate resource use as a way to determine the points. And eConsults actually, within the non-traditionals, have a higher point value than some others, such as panel management and whatnot. Next slide, please. So this last one, I'm going to spend less time on it because this is not really launched yet. You can see this won't even launch with applications until later this summer. So this is a pilot program. Only about 5 to 8 county applications across the state will be accepted, and focuses again on the high utilizers of multiple systems, and requires collaboration between county agencies, Medi-Cal managed care, especially mental health, and other entities to collaborate on this very high risk, high utilizing, high cost population. And of course, the main part of this is coordination between these entities. Many of the target population beneficiaries, and this is, I don't think I did put this, this is Medi-Cal beneficiaries only. Many of these people get care in all of these settings, but are challenged because there's no coordination. Someone who's being seen in mental health, they don't know who the primary care provider is, or vice versa. Or someone, we've even heard cases where a person is hospitalized for psychiatric reasons, and the physical health side don't know that they're actually their own patients, or don't know that their own mental health people have been taking care of. So there's going to be a lot of coordination around data sharing, and coordination of care plan sharing. eConsult may be a vehicle that is used within this program, and because payments are for building infrastructure, possibly payments could be used for building eConsult infrastructure as well. However, because these are pilots only engaging some sites, and the target population is pretty small compared to Prime or the Global Payment Program, it's more likely that entities who are thinking about using eConsult or have eConsult might think about using it for this program, and it would require using it across physical and mental health and with plans. So there's just a greater coordination. So it's just one of those future possibilities. I think that's actually my last slide. I went through this very quickly, but I'm happy to take questions. I will say, for those of you who are not public health systems, one of the UCs or the districts or otherwise, in the community clinic setting, going back to global payment program, if you are contracted by your county health system to provide care for the uninsured, then there is coordination under the global payment program that you should be discussing with your counties, particularly in terms of eConsult, because that's something that you could both benefit from. On the Prime side, this really is strictly for the county health systems, the UCs and the districts, but the demand for specialty care comes from everywhere. So whether if a particular county health system is providing specialty care to their colleagues in the community clinic world, that demand for specialty care is something that they're going to have to be able to report on and improve on, and being able to get reports back to all of you is also going to be crucial. So there may be discussions around that as well. So I will pause or stop even and take questions from anyone.
Thank you, David. And a reminder to all of our attendees, feel free to type in your questions in the question box or the chat box. We will review those and convey those to our speakers, or raise your hand and I'm happy to attempt to pull you off mute. Give it just a minute for our speakers. One moment. Patty Porter, I see that you've raised your hand, but we do not have an audio link for you, Patty, so I'm going to send you an audio pin. It's not been enabled at this time. One question has come in, David. Thank you, Patty. What is your sense of how eConsult will be defined? Does a patient visit need to be avoided in order for this definition?
So, and I'm going to assume that that means under the global payment program, as there is no specific requirement to track eConsults under Prime. It's just the outcomes of how specialty care is being managed. So under Prime, under the global payment program, in the attachments to the standard terms and conditions, and this goes into all the details and includes the points and all that. There is a code, a CPT code, that has already been identified, that's already in use by some entities for tracking eConsults, and I'm trying to remember just off the top of my head, but there is a definition under that CPT code related to the provision, the sending of a request for specialty expertise from an originating site or referring site to the specialist. I just, off the top of my head, I can't remember the description, but it is within the global payment attachments, and those should be posted on the DHCS website quite soon because all of it got approved as of several days ago.
Terrific. Thank you, David. And yes, Patty had chat boxed in that she was referencing the GPP. Any other questions from our attendees? Either via chat, raise your hand, or in the question box. Thank you, David. We've not received any additional, but as they come in, I will be happy to convey those. So I think we are moving on to Delphine and your particular example, correct?
That is correct, yeah. So if we can go to the next, here we go, back to our evaluation framework. So again, I hope that with David's overall overview of both Prime and GPP in particular, we can see that eConsult provide one means of getting points, essentially, or showing a specialty delivery redesign that is pertinent to those two programs. And what we have tried to do is identify metrics that are valuable because of the evaluation of eConsult, but also valuable to those programs as well. And so let's drill down just on the first one for an example of how I would like and how I think we need to all think about these core metrics that we have drafted. So the first one is just the financial metric. Can we go to the next slide, please? So we see here just a blow up of that metric. This is directly related to Prime, and the measure that we have thought of, or that we came up with, was the number of specialty touches per population served. The idea being that this would be passively ascertained through either health system or hospital metrics or hospital electronic medical records, or the eConsult platform or e-referral platform that any system may be using. The definition that we had initially come up with, based on our experience in Lit Review, was to look at the number of specialty visits in person plus all the number of eConsults divided by an impaneled primary care population. And the reason to measure this was this would be an indirect measure for business case, and it measures access to specialty care, essentially. And you could look at trends over time, in part to see whether supply of specialty expertise via eConsult induces demand or not, which is often a question that has been posed to us by some of the payment plans. Now, the first question that comes up is this feasible? This is aligned with Prime. However, we recognize that the definition may not be perfect. In our conversation with some of our colleagues at Santa Clara earlier this week, for example, they pointed out to us that their impaneled primary care population might not actually, as the denominator, might not work for them. And for them, the more meaningful denominator was all the individuals that get referred to them for specialty care, so the people that they touch for specialty care. And so that was their comment to us in terms of the meaningfulness of this definition, that yes, it was feasible, but two, this definition was not meaningful to them, and then this was the edits that they had recommended. And so again, what I would like individuals to think about as you bring this back to your group is thinking about all the examples, and one, are they meaningful, and two, how you define them. So let's move on just to the next example, the next slide, just to give a slightly different example. So this is one example from the population health section of the quadruple aim. This was a measure of time to third next available new in-person appointment for any specialty that uses eConsult. Now, as we all acknowledge and recognize, the goal of eConsult is to prove access to specialty care and specialty expertise, both virtually but also in person, because the goal is to allow the virtual discussion to relieve some of the pressure on the specialty clinics and the individuals who need to be seen in specialty care. So this is a direct measure of impact, and wait time to third next available appointment is one that is often used in primary care, and a lot of the plans recognize as an important metric for access. So I think we all recognize that this is important and meaningful, but some of the feedback we have gotten, for example, from our colleagues from Alameda, rightfully so, suggesting, well, this is a commonly used measure and it is important, but it's so dynamic and there's so many other factors that are involved in how third next available or even next available comes out, that we weren't sure whether a pilot eConsult program might actually affect third next available. And in that case, do we really want it as a core metric, or should we include it as a supplementary or future metric down the road? So again, some of the thought process that I want to engage all of you in as we move forward. Next slide, please. So those were two examples that came from the financial aspect of the quadruple aim and the population health. I next want to just move to the care team experience and just highlight what we'd like to do with this box. You can see here in green that we are looking for satisfaction or dissatisfaction metrics for primary care providers, specialists, and staff, particular referral coordinators who may be involved in the referral process or consultation process. And you can see here in the definition that we have not actually included definitions in these boxes, partly because we want to make sure that a definition of satisfaction is chosen that is meaningful for each system. We recognize that general satisfaction is something that is important to capture in every system, but the actual question that you might use to define it might be slightly different depending on your workflow and how the eConsult system is used and deployed in each of your settings. So what we have come up with and what we will be sharing with every group, if we haven't done so already, is a survey tool that we have put together, again, based on literature review and other surveys that have been used in other jurisdictions across the US and Canada who are using and piloting eConsult programs. In that survey, we have a primary care provider survey, a specialist survey, and a staff survey that gets at some of these satisfaction items. And it is an online survey, and we have distributed it to several of you, but perhaps not all of you at the moment. And similar to this evaluation framework, it is a draft survey, and that contains a variety of domains. And we hope that those domains are meaningful for you. But we look forward to receiving specific feedback on whether the questions themselves make sense for your system and your delivery system and your eConsult program in particular, and how you might want to reword the questions to be even more meaningful for you and to help drive quality improvement and eConsult program improvement within your own system. So if we get to the next slide, we can just show you one example of both a primary care satisfaction question and a specialist satisfaction question. So for example, on this online survey, one of the questions is just this. Since the start of eConsult, how satisfied were you with your ability to get specialist appointments for your patients in eConsult clinics and non-eConsult clinics? And we have a Likert scale that your providers would be able to select. Next slide, please. We will see an equivalent specialist satisfaction question with a few more domains. This question just asks, how satisfied are you with the ease of the eConsult process? This gets at more of the workflow and the process itself. So asking specialists how they think of what their satisfaction is with reviewing or responding, with tracking eConsult requests, with its integration with workflow, whether they are satisfied with the reimbursement or work credit, if it is there at all, and your ability to communicate with the referring provider. And again, each of these questions get at specific workflow items, and our hope is as we collect the online responses for specialists, PCPs, and staff for each group, collate those responses and give back both the raw data to each of the individual systems as well as some basic analytics, we can help each other learn, have shared lessons learned, but also help each system drive improvement to come up with a system that is as user-friendly and efficient as possible. Next slide, please. So at this point, you may all be asking, what are the timeline and expected deliverables related to eConsult and related to the evaluation that we are moving forward with? And here we have just overall for the next 6 months, what are some of the Prime and eConsult deliverables that we would like to see? So I'm not a Prime expert, so David can jump in whenever necessary, but my impression, and based on our understanding, was that in April, we had Prime participants need to have a 5-year project plan that is due. And then because these plans may include eConsult plans or eConsult projects, if your team is using eConsult as a means of refining ambulatory care for Prime, for eConsult, what we would like to see from you, and this is where your homework comes in, is which of these core metrics do you think are feasible for your system, which of them are meaningful for your system, and what are the numerator and denominator that make sense to you. And we will come back to all of you individually to have a conversation about this, such that in May, our hope is to come up with a consensus to finalize shared metrics for everybody for this impact evaluation. At the same time, we'd like to identify with each group the survey edits that would make the survey most meaningful to each of your systems individually. And we would like to get consensus and get final sign-off for the implementation metrics from all grant participants, including not only those who are currently piloting eConsult or eReferral, but also those who are still in the planning phases or think that this might be something in which they would like to engage in the near future. I think this would be helpful not only to start thinking about how you might want to measure some of this impact once you delve into and actually pilot an eConsult program, but also I think a lot of your thoughtfulness and feedback in trying to set up an eConsult program will be helpful as we refine some of these metrics. In June, there are a couple deadlines related to Prime. And then in July, or sometime in the summer, depending on how things are going over the next couple of months, we'd like to administer the online satisfaction surveys, or we'd like you to administer the online satisfaction surveys to your providers. We will then, in September, be able to provide some data back to each of the grantees about their online satisfaction responses. And that is also when we'd like the core metrics or the core measures, the data pertinent to those, to be provided to us so that we can look at them and start giving aggregate data and shared lessons to the entire group. And you note that this coincides with when baseline data are due for the Prime metrics. And then lastly, in October, or sometime around then, is when I believe the first payment for the Prime program is delivered to the hospitals. We have nothing specifically in that month for eConsult, but this is when we expect that we will refine some of the data for the next time that we do want to evaluate eConsult and really refine further what went well or what didn't go well with our evaluation process and how to further align it so that it's seamless with both Prime and GPP moving forward. So I'll actually stop there because that was a lot of information and perhaps open it up to questions.
Delphine, this is David. Just one comment is that for all of the county-run health systems that are part of this eConsult project, all of them are required to do the specialty care redesign project under Prime, so all of them will be reporting on those 3 metrics that I mentioned earlier related to eConsult.
Great. And those data are for September, is that correct?
Correct. They submit that data to the state at the end of September.
So again, it behooves us to make sure that our goal is to make sure that what we are asking for eConsult is perfectly aligned with that. Again, our goal is not to create additional work, but to really leverage all of these programs together such that we can better drive improvement in specialty care delivery.
Delphine, a question to consider is, so the group can look at those 2 evaluation framework sheets that you've delineated obvious questions, and you want the feedback on it. Who on the project teams should consider sitting down and reviewing that so you get the diverse input and focus that you want? Who would you recommend?
I think that's a great question. I would recommend the implementation team, so those who are actually delivering and trying to pilot the eConsult program or plan for the eConsult program. as well as all the stakeholders in whom you have brought to the table for implementation or for planning to implement an eConsult program, partly because their viewpoints will be important if you're still in the planning phase. I think their viewpoints and their acknowledgement of what is important to evaluate, I think, will help move that conversation forward. I also think the data folks, so individuals who may be involved in actual data structure, in pulling data for hospital metrics, for the PRIME program, for the GPP program, would be important to have at the table, because they're the individuals who know explicitly what are the numerators and what are the denominators that we plan to use or are thinking about using for PRIME, for example, or for something that is related to GPP, and then think about how you can lay over the eConsult metrics on top of that.
Great, thank you. And then another question, David, I'll pose this to you. Just a clarifying question. Is eConsult then one of the optional domains, or is it considered a required one within the PRIME structure?
So eConsult itself is not required. It is encouraged, and it's called out in a number of different places in terms of a strategy with which the PRIME entities can use to improve their or achieve their targets on the metrics. That being said, it's going to be very challenging, if not impossible. I don't want to say impossible. It's going to be very, very challenging to achieve metric targets without having eConsult in place. I mean, particularly the specialty care request for specialty care managed through non-face-to-face mechanisms, the referral reply turnaround, the benchmark on that one is within 4 days, and so how close are you to getting that? That's going to be very difficult to achieve without eConsult. And on the GPP, it is an optional service. You're not required to provide any particular service under Global Payment Program, but it's certainly one of those that a number of our county members are using to get points and to provide better care to the uninsured. And like I said, it's one of those higher points on the non-traditional side.
Great, thank you, David. So I'll open it up for any other questions from the group. You can type those in the chat box or the question box. A question has come in about posing to David. Is it possible that the approved eConsult CPT and definition could be sent out to all of the grantees when it becomes available? So when the CPT code specifically and the definition specifically for eConsult is available, I presume that's a resource that the TA providers can route around to all of the grantees associated with the eConsult initiative.
All right, I realized I was on mute. Yes, I can definitely get those out. Couldn't understand why no one was listening to me. Yep.
Appreciate that, David. Any other questions from the group? We know this was a lot of information to take in, and some of it you've had the pleasure of hearing as the development stages go, but we wanted to make sure that we provided an opportunity to see it in the framework and the context of eConsult. So I will just raise your hands or give you the opportunity one more time for questions to any of our panelists. Seeing none come in. Just a few more logistics. So thank you to all of our panelists for your time today and your expertise in sharing it with all of the grantees, contextualizing it for some of the grantees that aren't quite there yet, but also setting the stage for important information from all of the grantees. Is it feasible? Is it measurable? Will it demonstrate impact? The logistical updates for all of you. We have been recording this webinar, so slides and the recording will be distributed to all registered attendees as well as the general distribution list. So you'll have copies of all these materials, the reference tables that Delphine reviewed and would like input back on, and the information and update provided by David. So that should go out later today or first thing tomorrow. So within the next 24 hours, you'll have both the recording and the PowerPoint deck to reference for you or to share with your colleagues. Seeing no other questions, I thank our speakers again for a terrific webinar today and wish you all a wonderful afternoon. Take care, everyone.
Thanks, Bridget.